And discussion focuses on increasing efficiencies and looking at opportunities for the provision of healthcare in Africa. And we have Dr. Dan Kaseje as our presenter, and we have Dr. John Simon as the discussant. I've known Dan. Dan and I reconnected after almost 20 years, a little bit more than 20 years. We were colleagues in Kenya, and he's joining us from Kisumu, where he's director of the Tropical Institute for Community Health and Development in Africa at the Great Lakes University, and is vice chancellor of the Great Lakes University, a new university there in Kisumu in Western Kenya. He was also worked with. Was the executive director of the Christian Health Association in Kenya, and has worked with the Christian Medical Commission and World Council of Churches, has worked with Aga Khan, has worked with the Red Cross and Red Crescent societies, and has been lecturer at medical school. So Dan comes to us with a breadth and depth of experience and knowledge and on-the-ground experience. And I think part of the ideas that Dan's going to share with us today really will lead us to some practical dilemmas and practical solutions to these very important issues. Dan holds an MD, an MPH, and a PhD, studied at Liverpool, Harvard, and University of Nairobi. John Simon, the discussant, is the chair of the Department of International Health and director of Center for International Health and associate professor at Boston University. Another well-respected colleague and friend, and has been at the front lines of healthcare delivery, applied research, and public-private sector partnerships. He's on the board of INCLEN, the International Clinical Epidemiology Network. I just returned from Cairo to join us at this meeting, which I thank you very much, John. He's been working up in Boston and teaching there, has done work on the impacts of HIV/AIDS and workforce issues, and also on applied research for the past 20 years. So we're very happy to have John with us as well. I think we should begin without further ado. So let's welcome Dan Kaseje.
Thank you, Vic, for your kind words, and thank you to the leadership of the Wilson Center for inviting me and giving me this opportunity to renew contact with many friends in the history and my profession. There are many of them, such as, I do not know whether he is now professor or something, Harrison Spencer, David Wood, and Vic, and many others that tried to transform my life as we worked together in Kenya. But as you will see, they didn't succeed very much because they did not make out of me the kind of health bureaucrat that I probably should be. And maybe when I was invited to come here, I was invited as a health bureaucrat, international health. So I'm still very much frontliner in the areas of health. I haven't gone far beyond the village and community health workers and things like that. So when I come to sharing with you the sort of emerging model as I see it, you will probably look at it from that point of view, that I tend to be a very, I tend to have been, my development was arrested at that level of the health center and dispensary and village, and where health development happens, and where I still hope transformation will start and hopefully influence the rest of the health systems in Africa. And I think part of the problem, which includes me, is that we haven't, we have a lot of learning and a lot of progress and a lot of studies and a lot of science and so on, but the science of engaging effectively at the front line is, I think, where the gap is. That all of the things that we have learned and models that we develop and approaches that we have are very good. But in Africa, perhaps, where 70% of deaths occur in the household, at home, and large proportion of that without any contact whatsoever to the health system. And we begin to realize that we may be putting a lot of our efforts where the issues are not. And until we are able to engage and reach out to the household where healthcare really does take place, the situation will probably remain the same. Now, a lot of the things that we talk about in meetings like this, I think, have been mentioned, have been talked about, and in conformity with what I should do in meetings like this, I also had similar slides. But I thank my colleagues, Avik and David, for having presented them very well. So I will probably go over them very quickly indeed. Yeah. Yes, well, the need is, well, okay. Then my presentation then is outlined as shown. I want to re-emphasize what the need is, the problem, the context of our health and development work in Africa. What do we learn from history? I want to highlight from that history some opportunities, and then share with you a model that we are struggling with. It's not a new model, but something that we are trying to re-articulate, reorganize to see whether it can improve health activities and therefore health impact at the front lines. We have said many times that the investment in health, particularly by our government, is rather low, so that cannot be overstressed. When we come to the interventions that matter, the preventive interventions in our countries, many of them are still very low coverage. Thanks to David for highlighting some of the hopes where some achievements have been made. In terms of who is providing health care in our country, as in many countries, the private sector, where I believe one then needs to define private sector in order to respond adequately to what Peter had to say in response to what was being presented already. But by private sector in this particular slide, I include the faith-based organizations that are providing indeed a very large proportion of services, and also other informal sources of care. I'm not limiting this to the NGOs or to the donors at all. So the responsibility for care is largely, at least more than 50%, in the hands of the private sector, and this is the sector that does not usually receive support either from the government or from the bilateral sources. We had a situation in Kenya recently where this was brought to a head. I'm glad that many of you are very familiar with Kenya, so I have to be very careful what I don't say. But when we had the Clinton Fund to hire nurses, and Kenya is one place where the public sector now pays much better salaries to health personnel than my type of private sector, the church. And so the church, the health workers in the church services are always looking for opportunity to join the public service. And when Clinton brought money to hire 1,000 nurses, and the public service advertised these positions, well, all the personnel from church hospitals applied. And about 800 of them were recruited, and that emptied the hospitals, and the hospitals were brought to their knees. And actually, the good thing, of course, is that then the churches organized and went and saw the president, and some of this had to be reversed. And some of the colleagues, the personnel that were hired, were then allowed to stay and work in the health facilities. And it also started a process where we are going to have perhaps a more coordinated, collaborative framework in which the sector-wide approach in health will include automatically the private sector in terms of the faith-based structures, not as a project, but as a long-term arrangement, which will not change whether Clinton money is there or not. Everyone has referred, of course, to the workforce crisis in Africa, the issue of availability. As you can see, the number of personnel available per population, head of population. Availability is generally low, but as you also are aware that because of HIV and conflict and other things, the available health personnel are affected and continually reducing. There is also the issue of the brain drain. The brain drain from our countries to elsewhere is a problem, but I think it is perhaps not as big a problem as brain drain within the country, where the best personnel from the public sector tend to take jobs in the temporary NGO 2-year funded projects that are running in all directions. Today they are in this direction, tomorrow they are in another direction, so on. And there is really no overall improvement. And they tend, because they pay better, they tend to take the best personnel. So that, for me, is even a bigger brain drain. Not too many of our nurses have the opportunity to go to work in UK. Perhaps they prefer more from South Africa and places like those. In terms of physicians, of course, we do not, in our countries, as you can see, depend on physicians to deliver care. So they are not a serious issue. I think if you touch the nurses, then you are touching the health workforce. If you touch the physicians, our systems will still survive. The only problem is that the bureaucracy or the leadership is provided by the physicians, whether they know how to do it or not. Well, we talked about not sugarcoating our situation, and I vote for that too. The issues and the context in which we have to deliver services is a context where indeed there has been a lot of improvement over the last 50 years. But the problem is that the improvement is not universal. The problem is that disparity is greater. And if you look at where perhaps the improvement even in mortality rates have come from, perhaps there are sections within our communities that have the same rate of mortality as you would have anywhere in the North or in the US. And there are sections in our same communities that have really, really horrible mortality rates. So disparity is a major problem as improvements take place. Colleagues were struggling with me yesterday as I was trying to present unrealistic models according to them, because even in those models where we talk about participation, there is still disparity in participation. So that is the problem that we deal with. The problem of delayed care. Many of the poor tend to leave coming to services too late, and they try cheaper, more available alternatives too late. So they come to the public service, to the conventional care system as a last resort. And so they come too ill, too late, and therefore too expensive to care for, both for themselves and for the systems. The traditional systems that seem to be more available at and more accessible, both in terms of design and in terms of acceptability, tend to continue to be ignored. And so if you take an example of my own country, Kenya, there is really no regulation whatsoever that is provided for the informal systems. So people receive care that no one is actually regulating. And therefore, if you know that, for example, in the conventional care systems, we still have quacks, people who try to do conventional medicine without the qualifications. So the same in the informal sector and the traditional sector. There are many that try to do that kind of practice without the qualification. And usually we then blame the whole bunch of them because of the few who are quacks among them. But because there are no regulatory systems, there is no way to set standards and set mechanisms that will control that system. And as I tried to allude to, it's also very difficult to develop the kind of partnerships at the front lines because the professionals are trained and brainwashed in a different kind of way and see things in their own way, believing that they see things as they are, not realizing that very often what they see is through their own lenses and may not at all relate to the realities of the people that they serve. And so developing meaningful partnerships becomes very difficult. But we have hopes. We have hope. We have hope in history. We have hope that something right happened after independence. And for nearly 2 decades, a little bit more than 2 decades, there were gains. There were gains in terms of reduction in disease, in reduction in mortalities. And those gains were sustained through the mid-80s and towards the end of the 80s. It might have been, since that is the time that these colleagues here were there, that maybe they were doing something very good. And maybe part of the solution is for them to come back, since they did not transform some of us to be able to do what it is that they were doing right in those days. But we have seen the trends in the 90s. Something has happened in the 90s that has changed the scenario completely. If you look at the trends in my own country, all trends in terms of service utilization, trends in terms of coverage, trends in terms of mortality rates and so forth, something happened in the 90 to 92. And it has gone the opposite direction, and we are more or less back to the early 60s in terms and rates. But we have also tried to compare ourselves with our neighboring countries, Uganda and Tanzania, and somehow the trends are better in those countries, and we have actually crisscrossed with Tanzania. So our rates are now higher in terms of bad things and lower in terms of good things as you compare with Tanzania. So something that they're doing there is a little better than we are doing in Kenya, trying to adopt perhaps the things that we are not quite able to use very well. So anyway, the trends, some of these trends have been reversed, as I've mentioned. We have talked about the growing population, or rather one could say the abnormal transition, demographic transition, affected both by HIV and the other normal aspects that we have already heard about. We have weak systems of care, and as I've already mentioned, the non-formal sector of health service provision continue to be ignored. I think that as we continue to look at possible hopes upon which one has developed the model that I was going to try and share with you, is that I think the health sector reforms is a useful framework for improvement of the health systems in our countries. One has to accept that. The only problem is that the usual frameworks that are developed elsewhere as being useful and the same for application in every country and in every community in Africa just does not work because of what has already been mentioned. The diversity in the continent is great. The reason that I believe one of the reasons that Tanzania is doing better than us now is that they do have a decentralized system in other sectors. And so the health sector is able to decentralize. In Kenya, we have no decentralized system anywhere. It's only the health sector was trying to decentralize without a structure to contain the decentralization. So of course you continue hitting your head on walls for a very long time. So it seems like we needed a kind of a modified sector reform for our country, if you like. And I believe that if you go to Somalia, it will be different. If you go to Ethiopia, it will be different. If you go to Uganda, it will be different, and so on. So the common frameworks that are developed elsewhere are well-meaning and brought to apply in every situation, just sometimes find it difficult to be modified. So we do need some modifications for this to fit. We've talked about the primary health care, which I think was another opportunity in history that came up with principles, strategies, and activities that were very appropriate for our systems. Now, both of these initiatives, policy initiatives that were very, very good, I think there was greater enthusiasm elsewhere than inside the countries. And even though people voted for them and committed themselves to implement, perhaps the political will was not quite at the same sort of level, and so the funding and the direction and the efforts tended to be external rather than from within the countries. Primary healthcare, of course, emphasized community participation, intersectoral collaboration, partnerships, reorientation of the health personnel so that they would be more consistent with the context in which they work. And these are positive elements that we have learned from. And of course, when I present the so-called model, Harrison Spencer will tell you, well, but that's not new. That's what we were trying to do back in Saradidi in 1979, a bit more than 25 years ago. So, but as I said, I still think that some of those principles that we are trying to promote then are the principles that perhaps we do need to go back to, that we do need to strengthen or to develop linkage between the health system and the people served. There needs to be dialogue, and if possible, if that dialogue was information-based or information-driven, then perhaps it will enhance demand on the part of the consumers. It will also enhance accountability on the part of service providers, and it might also enhance responsibility on the part of the consumers. An element that has been echoed here is that perhaps the population structure will change in the future, and that the current emphasis or focus only on mothers and their children will be inadequate very soon, and already inadequate, because now I need hypertensive treatment and I need service anyway, like anyone else. And that's why I think the focus on life cycle is important, that we need to look at the life cycle and the kind of essential care that is needed at every stage in the cycle. And that is the framework that you find in our current health sector strategic plan 2 by Kenya for the next 5 years. We shall be focusing on those diseases according to those stages in the life cycle. And what we are doing in this model is that the Ministry of Health has requested us to develop an implementation strategy that might enhance the implementation of the strategic plan, so to speak. And we want to highlight the following, that decentralization indeed is an important element, as we have learned in health sector reform, that a reorientation in the skills mix amongst service providers because of the changing scenario and the changing emphasis, the skills that people gained when they were trained. Usually people are trained for the current situation and sometimes for the past. People are not trained for the future. And now that we are in future, when people were trained, those who were trained 10 years ago are now in the future of when they were trained. They need a reorientation in order to bring their skills at par with the service delivery needs of the context in which we now are. We need to enhance accountability and responsibility, and we were identifying that in fact there are structures within our countries where resources are sequestrated away from service delivery. And there are, I can think of two such structures. One, the universities, where you have a lot of very well-trained people, but they do nothing most of the time. They teach one lecture a week and so on. They could be available for engagement in the health system as facilitators of the kind of models that we're talking about. The other is the armed forces. We also have armed forces, and we have no Iraq to send them to. So they are also just sitting there. So these are structures within our countries that could be better utilized. They could be made, mobilized, and be made more available to engage in services. And some of the service delivery situations require the kind of discipline that will come from the armed forces. That is a framework for planning we are talking about, and trying to promote participatory planning at all levels, so that the planning that the plans that are developed at the district level are informed from the lower frontline levels. And we have developed this model, the Wheel of Change, that attempts to engage the communities at all levels through dialogue at all levels. We engage in carrying out an assessment of the situation in order to identify local priorities, and then through a reflective process identify actions that are both effective and doable, not necessarily ideal actions, but doable actions that are effective. And then we plan how to do it, and then various partners act in the things that they can do best, everyone acting within areas of their own influence. And that this process over time, we are toying with the idea of the Rapid Results Initiative, where every 4 months we can sit together and see where we got to. Everyone is expected to come up with results within 100 days. The Rapid Results Initiative built into this whole process, so that within a year we can see some change. Some areas of change happen very quickly, and other areas of change are more difficult. And you can see that the driving force there is information, is data. And we are talking about data from the community-based information system, complementing the health facility-based information system. Some of the indicators that we want to focus on, simply because they are more easily measurable at those levels, are indicated on that particular slide. There are many indicators that we can look at, but looking at indicators that can easily be collected and with adequate accuracy and precision, and can be shared to inform dialogue at the front lines. These are just some early results. My colleagues insisted that I must show that this model seems to have some positive effects. Otherwise, I will be thrown out of this meeting. So I came up quickly with a slide which shows some of the changes that have happened. And I think that looking at one area where things have happened rather quickly is improving personnel practice, personnel attitude, in order that the consumers are better satisfied. We are going through a system where, in fact, in Kenya, in many communities, people just stopped going to health facilities. And I think starting to improve the health facilities and rebuild the credibility of the health facilities is a very important element. And we have seen that happen, except in waiting time has not changed very much, because maybe, the more queues you now have, waiting time perhaps is a difficult one. But the dialogue about it, and then the improvement in essential drug supplies is something that perhaps also has received a lot of attention of late, and we have not seen a change in that. But in everything else, we seem to have seen a change. Even a change in the immunization coverage, which when we started was very low in this particular community, in this particular division. This division is an area covering about 20,000 people. So we have a health center and communities of about 20,000 people, and we are measuring this change. And we are trying to do this in about 6 districts. This is an example from one district, Suba district, which for those of you who know Kenya, is one of the districts with the worst indicators in the country. So in summary, we have learned that we can indeed improve skills through training to reshape the skills of personnel to be relevant to the current context. We need to learn from information flow up and down, but also learning from sites of success. The positive deviance that David talked about is a useful model for individuals, but we think that there can also be positive sites where success have happened, which can also be available for learning for those who want to make similar changes. There may be need for a facilitator, and that facilitation need not always come from one source, and there are several people or institutions that may have capacity to facilitate this process. We've talked about the importance of information, both community-based information and health facility-based information. And we have also talked about networking, that the scaling up should be through networking rather than through dissemination of the same model. Because as people network, they learn, and they then they take what is possible and they leave what is not possible for their own situation. And we are not going to say that this model is the model that now must be scaled up, but we are saying that this model may have elements that people can learn from, and various people from different parts of the country, from different, even parts of the same district, can pick up things that they think are working for them and leave out those elements that are not working. Thank you for listening.
John?
Dan, thank you very much. I share with Dan about 1986 is the first time that I had the privilege of meeting him in Western Kenya, and have followed your career. I actually don't find you stuck in time by some of your comments, but I wanted to thank you for those comments. Thank Vic and the Wilson Center. Unlike David Oot, who had the advantage of having to do homework, I actually had a chance to look at this presentation only this morning. So I have less of a historic view, but what I'd like to do, if I may, is make sort of 5 observations or points. One, I share with you, Dan, a sense that the real action is at the household, because that's where the transaction around health occurs. And I think I share with you a sense that people are really a key to this theme of improving the efficiencies in the health sector. But I might argue that your ideas on how to get there may in fact need some reorientation or some refreshing. We are struck by the fact that we've been in this game for 50 years. in Africa post-independence. And what do we know? We know if we go back to 1960, the African continent was doing better than its East Asia neighbors. So though you may say there was progress in the 60s, 70s, and 80s, relatively that progress was slow relative to some of the potential progress that could have been made on the continent. And therefore, I wonder if we're at that moment of time that Thomas Kuhn told us about when he wrote about the structure of scientific revolutions, where he said, look, contradictions build up, and we get more and more evidence that what we're doing isn't working. And then we actually get to what he called a paradigm shift, what Malcolm Gladwell calls a tipping point. And I would argue that we probably should be doing all we can to accelerate the tipping point, because I'm not sure that our history will serve us well if we continue on a modification of a linear experience, given what we've learned in the past 45 or 50 years in primary health care in Africa. So I want to throw an alternative view out just for discussion. What if we said we'll accept that the actions at the household, and it's based on people, and actually begin to incentivize people to provide high-quality health care? And we have some models about this, and we have some understanding from economics about human nature. And in fact, I think we need to be thinking fresh, not about the public sector capturing or taxing the private sector, but actually figuring out how we can create a cadre of trained health workers who have two things going for them. One, they're paid a living wage. Fundamentally, if we expect the health sector to improve, we have to pay your nurses in your facility a living wage, so that the government, the internal migration, you're not as vulnerable to. And secondly, I think on top of that living wage, we ought to think about how to incentivize them. And we have some examples of that, which I'll come back to in my fifth point about where do we find ideas and where do we find experiences. But investing in community-based care, yes. Investing in the women who provide that community-based care, absolutely. But beginning to value that female labor at something approaching a living wage rather than effectively zero, which if you think about it for a second, is what we're saying about orphans' care. There's going to be 15 to 18 million orphans on the continent, and we're expecting that the African extended family is going to absorb this burden. Well, who is that? That's elderly women, right? And with the exception of South Africa, which has a cash transfer that follows that children, by and large, most of the programs are assuming that that extra burden would be borne by households without dealing with the economic impact of that on the household or the wage opportunity for the labor itself. So I think, UNICEF in this case has it quite wrong on family-centered care. I think we need to think creatively about institutional-based mechanisms to deal with some of the extraordinary burdens. And it was interesting that you turned to the armed forces as one of the institutions that might help do that. So point number one, people are key, and we need to incentivize them to produce high-quality care as a paradigm shift in how service delivery at a primary care level may be organized. The second point I'd like to make is that I've never understood why people think tradition and culture are fixed. They're only fixed when we make a museum exhibit of it, and then even so, 20 years later, we change the museum exhibit. Culture is dynamic. Traditions change. And therefore, the people who argue we can't do certain things because of tradition and culture on the African continent, to me, are remarkably ahistorical. There are huge social movements, and I would argue that the church movement is transforming the culture of Africa. The two biggest religions in terms of growth in the world are Islam and the Pentecostal movement. Well, what do we know about the Pentecostal movement? We know it's one of the most dynamic forces on the African continent. We know it's growing by leaps and bounds. And when we look at the Pentecostal movement in Central America, we find a very interesting story. It put women in the labor force. It reduced alcoholism. It puts a high priority on marital fidelity and therefore reduces some risk behaviors on HIV. There's things within the Pentecostal movement. Let me make it clear. This is not a culture that I have any affinity to. But there are things within the Pentecostal movement which are very pro-public health. And it's a huge dynamic on the African continent right now. And I wonder if we can capture changes of culture rather than arguing that culture and traditions restrict our ability to deal with some of the challenges. Third point, we've been talking about improved accountability for a long time. And one of the things that I think, and accountability I think needs to come from multiple directions, okay? There is voices out there that talk about the moral imperative to meet some of the needs on the African continent right now. And I share that sense, and I appreciate the organizing that's gone into trying to pitch it that way. But where's the moral imperative for equality in accountability and equality in dealing with the corruption issue? And I think if we don't actually deal with the corruption and accountability issue at all levels, the donors holding their bilateral partners accountable for what they know is going on, and equally importantly and simultaneously, communities holding their own health service providers accountable for what's happening at the local level, are we going to get a handle on the fact that we have rampant and endemic accountability problems? And fundamentally, we need to attack that at multiple levels. And we get little surges of the bank talking about it and others, but nobody's really tackled that issue head on. And I think it's at every level of the system, from the donors down to the community provision of service. And I think that will improve efficiency, because what we're losing, our wastage in the system, is extraordinary. Fourth point, we talk about building capacity. And I think it's not only the capacity, 2 points and I'll finish, Vic. It's not only the capacity to provide service. I would argue that there's a tremendous need to build what I call program evaluation capacity. Are we learning from what we're doing? It is extraordinary to me that the United States government, with my tax dollars, can invest $15 billion in PEPFAR as the greatest uncontrolled public health experiment ever unleashed on the world, and then say, but we don't do research. Okay? We don't want to learn from our experience. We want to meet the emergency and serve. A more short-sighted, and this is changing, I give them credit, but a more short-sighted version of how you actually would program development assistance monies is tough to see. I think there's a huge need to begin to do some serious program evaluation research to learn what is working and to feed that into program activities. My last point. Where do we find ideas for modification? And I heard somebody say, there has to be African solutions because this is an African problem. If there is ever a moment in history where Africa needs to look outwards rather than inwards, now is the time. Are there problems with the relationship? Yes. Are there trust issues? Yes. Are there problems with the donors? Yes. But an inward strategy, given the history of what's happened on the African continent in public health in the last 50 years, is really scary to me. And in fact, David's comment, the positive deviance he couldn't find on the continent. Well, we have some positive deviance out there, and we need to think about, are they applicable to country-specific activities? Because I don't think you can talk about Africa, but are they applicable in Kenya? Are they applicable in Tanzania? And I would argue that the BRAC experience in paying community health workers to train people how to do diarrheal disease control and incentivizing them based on the quality of what they do is an idea that we only will find if we look outside. We will only try to figure out whether social insurance for the poor is doable if we look at the Mexican experience in Popular Seguro, what Julio Frank's government has tried to do with the unemployed and the uninsured. Now more than ever is a time for Africa, I believe, to look outwards in collaboration for ideas and for decent partnerships, rather than to assume that the answers reside solely within the continent. So people are the key. Evaluating our programs in order to improve what we're doing is, I think, a huge gap in our capacity. Dealing with corruption and accountability is part of technical efficiency, and now's the time for Africa to look outwards towards the world for solutions rather than inwards if we're serious about improving the efficiency in health services delivery. Thank you.
Thank you, Jonathan.